So, good evening, everyone. As in the previous lecture, we have discussed about uh, ECG and its basics and the conceptual interpretation which has to be done during if we are studying an ECG report. So I have just covered that topic so that it could be helpful for the future topics, because all the topics which will be discussed in the future relates with the ECG. So now today we'll be discussing about the second type of blockage, that is called as AV node blockage. AV node blockage, or also what you call it as junctional blockage. Do you know why AV node blockage is also called as junctional blockage? So the answer for that is, as you know, AV node is present in the junction between atrioventricular, in the between the atrioventricular walls of the four chambers. So it is present in the junction. So if there is a blockage present over there, then we define the term as junctional blockage. So today, what were the forum of our discussion is, what are all the types of blockages, what are all the how do you classify the AV node blockage, about its classification, and what are all the factors which may leads to AV node blockage. So the first thing which we'll be discussing is factors which leads to AV node blockage. Factors which leads to AV node blockage. So coming up to the first factor which will leads to AV node blockage is, if there is an ischemia in the sense a type of embolus form or any type of injury which is found in any of the artery or any of the organ, is called as ischemia of the AV node or AV bundle fibers. So this could be the first factor which may leads to AV node blockage. Then the second factor which may leads to the AV node blockage is compression of AV node bundle. Compression in the sense, if there is any pressure or some kind of force exerted to the AV node, so this may also leads to the blockage, because it may leads to impairment of transferring impulses from atria to ventricle. So let me write it down over here. Or now coming up to the third factor is, if there is any inflammation found in AV node or AV bundle fibers. So if there is any inflammation found in AV node or AV bundle, this is also a sign of blockage, and two, it may also indicate some other types of disease such as diphtheria. So you might have learnt about diphtheria in microbiology. So the bacteria which causes diphtheria is Corynebacterium diphtheriae, which is a gram-positive rod bacteria. And the another thing which may also leads to is rheumatic fever. You might be knowing about rheumatitis, about osteocytic rheumatitis, which usually occurs in synovial types of joints in our body. So this is also a common factor of rheumatic fever. So the inflammation are found in AV node, which also indicates about the AV node blockage, and it may also indicate other types of disease such as diphtheria and rheumatic fever. So coming up to the next factor is extreme stimulation of the heart by vagus nerve. Extreme stimulation of the heart by vagus nerve. So how do you define this factor? So what is the reason behind this factor? So if you take a look on this, vagus nerve, as we are all known that vagus nerve is the 10th cranial nerve which is present in our brain. So usually vagus nerve is a kind of parasympathetic nerve. It has got a long preganglionic body and a short preganglionic postganglionic body. Usually we have got two types of ANS system. One is what you call it as sympathetic system and parasympathetic system. So if we talk about the sympathetic system, so let me write it down over here. Sympathetic system. If you talk about sympathetic system of ANS, so usually if we talk about its the pattern of the nerve, the preganglionic body is long and the postganglionic body is short. So I'm sorry, I forgot to mention about its length. So let me write it down over here. Is short. So we also call sympathetic system as cholinergic system. So why do we call sympathetic system as cholinergic system? Because the neurotransmitter which is used in transmission of the information from through the sympathetic system is acetylcholine. So as the name itself indicates that sympathetic system is also called as cholinergic system because it uses acetylcholine as a neurotransmitter in order to transfer the information from the CNS to the receptor to the sensory receptors. So the another one, what we call it as parasympathetic system. I am explaining you this one because it would be helpful to manipulate the fact of this statement. So let me explain it so that you could be able to understand the factor of AV node blockage. If we take it in parasympathetic system, usually the preganglionic body is short and the postganglionic body is long. I'm sorry for the mistake. I'm really extremely sorry for the mistake. So let me correct it down one of the statement. Usually if you take it in parasympathetic system, the preganglionic body is short and the postganglionic body is long. And if you take it in terms of sympathetic system, usually the preganglionic body is long and the postganglionic body is short. So what is the another name what we could define the parasympathetic system? As I have said, we also call sympathetic system as cholinergic system because it uses acetylcholine in the form of neurotransmitter. So what we call what is the another name for parasympathetic system? So the another name is anticholinergic system. Anticholinergic system. So why do we call parasympathetic as anticholinergic system? Because both the actions of this system are opposite of each other. If we talk about sympathetic system, it usually increases the stimulation of all the organs. Usually sympathetic system is the system where it increases the stimulation of all the organs. But if you take it in terms of parasympathetic system always usually is responsible for decrease in stimulation of all the organs. So we call parasympathetic system also as anticholinergic system. So now coming back to the fact, which is why we usually the above one which I have mentioned is if they usually parasympathetic system is responsible for decrease in stimulation of all the organs. So if you take if you take heart as an example of an organ, if there is an extreme stimulation of heart by vagus nerve, which is a parasympathetic system, then there will be decrease in heartbeat. So if there is any decrease in heartbeat, then obviously there is a low transmission of simple impulses from pacemaker and the conduction of the impulses to the other parts of the heart by Purkinje and bundle of His. So if there's an extreme stimulation of the heart by vagus nerve, then there will be high case of bradycardia. This may leads to bradycardia, which is low heartbeat. If there is extreme stimulation of the vagus nerve, then there will be decreased heartbeat, and if there is a case of decreased heartbeat, then it may lead to bradycardia. So usually in bradycardia what happens is there will be decrease in exciting of the tissue and transmission of impulses from pacemaker to the junctional node and to the bundle of His and to the Purkinje fibers. If there is too much decrease in the conduction of impulses, then automatically there will be a blockage found in AV node, because although sinoatrial node is conducting the impulses, but the impulses which are accumulated in the AV node due to the extreme stimulation of vagus nerve and due to slow heartbeat, it will elongate its a period of transmission. Usually, as I've mentioned about the AV node, it usually delays the transmission of impulses from atria to ventricle for a period of around 0.1 second. But this period will be increased during this time due to extreme stimulation of vagus nerve, and this may also leads to heart block. Hope you might have got this point. So the next and the last factor is degeneration of AV conduction system. The last factor is degeneration of AV conduction system. As the statement itself says that if there is any degeneration, or if there is any a kind of what we call it as malfunctioning of AV node conduction system, or if there is any trauma which has occurred in the heart, it may, which may leads to the injury or degeneration to the AV conduction system. Then it may also lead to the AV node blockage. Okay, hope you might have got this point, and you might I hope that you understood all the factors which are to be which are responsible for even atrioventricular blockage. Now coming up to the types of atrioventricular blockages. Types of atrioventricular blockage. So what are all the types of atrioventricular blockages? So if we talk about the types of atrioventricular blockage, it is classified into 3 types. The first one is first degree heart blockage. And the second one is second degree heart blockage. And the last and the least one is third degree heart blockage. So how do we classify all these 3 types of blockages? What are all the factors and what are all the causes which may leads to the classification of these blockages? So let us discuss all 3 types of blockages thoroughly. So let's go to the first type of blockage is atrioventricular blockage, what you call it as first degree heart blockage. We also call first degree heart blockage as incomplete blockage. So why it is called as incomplete blockage, let us see. I'll be explaining you about this. So consider we have got an ECG report, a normal ECG report like this. This is the P wave, this is the Q wave, this is the R wave, this is the S wave, and this is the T wave. So this is the normal ECG report of a healthy person. Now sometimes what happens is, if a patient has got first degree blockage, then how do we conclude that the patient actually is suffering from first degree heart blockage? How do we see in terms of ECG report? So usually what happens is, the usual time interval between P and QRS complex is, so let me write it down over here. The usual time lapse, the amount of time where the two complexes are arised in the ECG, means the usual time lapse between the P wave and the QRS complex should be around 0.16 seconds. I'm sorry. The usually time lapse between the P and QRS complex formation should be around 0.16 seconds. Suppose if there is a formation of P wave in the ECG, then there is a mandatory fact that there should be around 0.16 seconds of gap after the formation of P wave in order to form the QRS complex. So what happens if this interval, the PQRS, the P and QRS complex time is increased? If what we call it as, usually what happens is, if there is any increase in length of the increase in time lapse between the P and QRS complex, or the increase in length between PR interval, usually this is called as PR interval. the gap which is found between P wave and R wave is called as PR interval. So if there is any increase in time lapse of P and QRS complex, or increase in length of PR interval, then what happens is, then the heartbeat get decreased. We are all known with the fact that if there is increase in time lapse, if there is an increase in time lapse of formation of waves, then like we conclude the fact that there is a delay in conduction of impulses in the heart. So if there is any delay in conduction of impulses in the heart, it may leads to the slower heartbeat. So the heartbeat is decreased. So this is the key point which has to be remembered whenever like we are classifying about first degree heart blockage. If there is any increase in time lapse of P wave and QRF and formation of QRS complex in the ECG, like usually the normal time lapse is 0.16 seconds, as I have mentioned. If the time lapse exceeds, if the time lapse exceeds more than 0.20 seconds of interval, then we can conclude that the patient is suffering from first degree heart blockage. First degree heart blockage. So this is the like a kind of diagnostic reason. Usually if we take in terms of ECG, this is the key point which has to be remembered if we have to classify about first degree heart blockage. So where do we often see the first degree heart blockage? So usually we see the first degree heart blockages in rheumatic heart disease patient. Usually we see this kind of heart blockage in rheumatic heart disease patient. So this is about the first degree blockage. Now coming up to the next type of blockage, what we also call as second degree heart blockage. Second degree heart blockage. So how do we classify the second degree heart blockage from first degree heart blockage? How do we differentiate between these two types of heart blockage? So let us discuss about that thoroughly. So like if we differentiate, I'm sorry for the delay, I got something here, so I'm really sorry for the delay. So if we really like, if we see in the aspect of ECG report, so let us take a normal ECG report as I have mentioned above. This is the P wave, this is the like I'll draw it in a blindly manner. P, Q, R, S, T. This is the normal ECG report. So how do we classify if a patient has got second degree heart blockage? So let me explain here. So if we take a continuous ECG report, so this is the Q wave, this is the normal continuous period of recording of ECG. So after 2 beats, if there is only formation of P wave, but there is, if there is only formation of P wave, but there is a dropping of P wave, but with QRST complex, if there is no formation of QRST complex, and again there is a formation of P wave and a QRST complex. So I can't draw that because I have not got enough space here. I will be continuing that diagram here. So again, if there is a dropping of P only, if there is only formation of P wave and there is no formation of QRST wave, and after some time again there is a formation of P wave and the QRST complex. As you have seen here, there is a continuous formation of BQRST complex, and after some time there is a sudden cessation of formation of QRST complex, and there is only formation of P wave. So if there is a finding of this kind of phenomenon in the ECG, so we can classify that type of heart blockage as second degree heart blockage. Now again, the second degree heart blockage is classified into 2 types. One is the type 1 Mobitz classification. One is the type 1 Mobitz classification. We also call the type 1 Mobitz classification as Weckenbach's periodicity. Now the second type of second degree heart blockage is type 2 Mobitz classification. So how do we define these 2 types of blockage, and what are all the severity of these 2 types of classification? So let us discuss about the first type, what you call is a type 1 Mobitz classification, or also we call it as Weckenbach's periodicity. So let us discuss this type 1 Mobitz classification in terms of ECG report. So always, like as I have said previously, second degree heart blockage is differentiated from first degree heart blockage in terms of ECG aspect. Like there is a continuous formation of PQRST complex, and there is a sudden drop of QRST complex after some time, and there is only formation of P wave, and after an interval of time there is again formation of PQRST complex. So how do we classify the type 1 Mobitz classification in the second degree heart blockage? So let me take a ECG report over here, a continuous ECG report. This is the P wave, this is the Q wave, this is the QRST complex, and this is the T wave. Like if I take continuous 3 PQRST complexes, if there is continuous formation of PQRST complex, then there is a sudden drop of QRST complex, and there is only formation of P wave. There is sudden cessation of QRST complex after continuous formation of PQRST complex. Means, like, if we take in terms of ratio, usually if there are four PQRST complexes forming continuously, then there is only one dropping of QRST complex after formation of all the four PQRST complexes which are formed before. So there is always a maintenance of ratio of either 4:1 or either 3:1. Always there is a dropping of one QRST complex in the type 1 Mobitz classification. So always there is a dropping of one QRST complex after formation of several heartbeats. So we have to remember that. Usually in terms of ratio, we take it as either 4:1, either 3:1, either 2:1. Means if there are formation of four continuous PQRST complex, then there is a dropping of only one QRST complex after the formation of four PQRST complex. Then after some interval of time, again there is a formation of again four PQRST complex, and there is a dropping of one QRST complex. Means the same cycle keeps on continuing after completion of a specified forming of PQRST complex in the ECG report. So this is all about the first type 1 Mobitz classification. If we talk about its severity, usually the severity of the patient is less. I'm sorry, just hold on for